A good day, students. Today we will have the lectures about the clinical and pharmacological characteristics of drugs for general and local anesthesia. Pharmaceutical care. No, that is the lecture outline about the inhaled anesthetics, local anesthetics, and very many other questions. Mechanism of general anesthetic actions. The principal molecular target of anesthetic actions are practically that have been studied are neuronal ion channel that mediated impulse conductions in the central nervous systems. Chloride channel, GIBA, and potassium channel remain the primary inhibitory ion channels considered legitimate candidates of anesthetic action. That is the scheme of the GIDA receptors, which provide one of this group of receptors which provide the central effect of the drugs. Inhaled anesthetics. A clear distinction should be made between volatile and gaseous anesthetics, both of which are administered by inhalation. Volatile anesthetics, halatan, enfluran, azafluran, desfluran, sevofluran, have low the vapor pressure and thus high boiling points, so that they are liquids at room temperature and sea level ambient pressure, whereas the gas anesthetics, nitrous oxide, xenon, have higher vapor pressures and low boiling points, so that they are in gas from a room temperature. That is the Galatan, the very popular inhaled anesthetic in real clinical practice. That is the enfluran and isofluran. Pharmacokinetics of these groups. Many diagnostics of minor therapeutic surgical procedure can be performed without general anesthesia using sedations-based anesthetics techniques. In this setting, regional of local anesthesia supplemented with the midazolam or propofol and opioid analgesics, for example, the ketamine, may be a more appropriate and safer approach that general anesthesia for superficial surgical procedure. This anesthetics techniques is known as a monitored anesthesia care, abbreviature MAC, and should be not confused with the minimal alveolar concentrations for the comparison of potence of inhaled anesthetics. Midazolam, 1 milligram in 1 milliliter or 5 milligram in 1 milliliter of these drugs. Propofol, very popular in real clinical practice, in anesthesia practice, surgical operation, surgical, maybe sometimes there is a diagnostic manipulations, and these drugs in real clinical work, the very important, has the very important place. Propofol, 10 milligrams in 1 milliliter. Another approach used primarily by non-anesthesiologists is called conscious sedations. This technique is produce elevations of anxiety and pain with less alterations to the level of the consciousness by using smaller dose or sedative medications. In this state, the patient retains of ability to maintains a patient's airway and is responsive to the verbal commands. A wide variety of the intravenous anesthetic drugs can be used in conscious sedations: diazepam, midazolam, propofol. Use of benzodiazepines and opioid analgesics, for example, fentanyl, in conscious sedations protocols has the advantage of being reversible by the specific receptors antagonist drugs, for example, flumazenil and naloxone. For example, diazepam, 5 milligram in 1 milliliter for the intravenous injection. Flumazenil as an antagonist antidote during the regulations of the concentrations of the inhalation drugs. 0.5 milligram in 5 milliliters, 0.1 milligram in 1 milliliters flumazenil. Deep sedation is similar to a light state of general anesthesia characterized by decreased consciousness from which the patient is not easily aroused. There are transitions from the deep sedations to general anesthesia is fluid and can be difficult to define because deep sedations is accompanied by loss of the verbal responsiveness, protective airway reflexes, and the ability to the maintenance of the patient airway. This state may be indistinguishable from general anesthesia. A practitioner with the expertise in airway management, anesthesiologist or nurse anesthetist must be present. Intravenous agent use in deep sedations protocols mainly include the sedative hypnotic propofol and midazolam, sometimes in combinations with potent opioid analgesics or ketamine, depending on the level of the pain associated with the surgery of procedure. Ketamine. In 1 milliliters, these drugs contain the 50 milligram of the ketamine H-chlor. The most important of gases that may be delivered in anesthesia mentioned, that is the 70% of the nitrous oxide, 29% of oxygen, and 1% of the isofluran at normal barometric pressure. Contains partial pressure 532 nitrous oxide, 220 millimeters oxygen, and 7.5 millimeters of isofluran. The partial pressures of anesthetics in the inspired gas mixture determines the maximum partial pressure that can be achieved in the alveoli as well as the rate of rise of the partial pressure in the alveoli. That is the special advice for introductions, the inhalated narcosis in the real clinical practice. Surgical department, sometimes the diagnostic department, sometimes it is the reanimatological and other departments. One of the most important factors influencing the transfer of the anesthetic from the lungs to the arterial blood is its solubility characteristics. Is described above the blood. Gas partial coefficient is a useful index of solubility and defines the relative affinity of an anesthetic for the blood compared to the affinity for the inspired gas. Disfluran for the inhaled and nitrous oxide, this form for the providing of the inhalations narcosis. Conversely, for anesthetics with the greater solubility bottom, halatan in fluran, more molecules dissolve in the blood before partial pressure changes significantly and arterial concentrations of the gas increases less rapidly. Blood. Gas partitions coefficient of 0.47 for nitrous oxide means that is equilibrium. The concentrations in the blood is less than half of the concentrations in the alveolar space gas. A larger blood gas partitions coefficient causes a greater uptake of anesthetic into the pulmonary blood flow and therefore increases the time required for FA-FI to approach equilibrium. Galatan and isofluran for the inhalations anesthetic effect. Two features that differentiate to the recovery phase from the induction phase. First, transfer of the anesthetic from the lungs to the blood during the inductions can be enhanced by increasing its concentrations in inspired area, but the reverse transfer process cannot enhance because the concentrations in the lungs cannot be reduced below zero. Second, at the beginning of the recovery phase, the anesthetic gas tensions in different tissues through the body may be quite variable, depending on the specific agent and the durations of the anesthesia. In contrast, at the start of the introductions of the anesthesias, the initial anesthetic tensions is zero in all tissues. Inhaled anesthetics that are relatively insoluble in blood and brain, they eliminated faster than the more soluble anesthetics. The washout of nitrous oxide, disfluran, and sevoflurane occurs at a rapid rate, leading to a more rapid recovery from their anesthetic effect compared with the galantan and isofluran. Galantan is approximately twice as soluble in brain tissues and 5 times more soluble in blood than nitrous oxide and disfluran. Its elimination, therefore, takes place more slowly, and recovery from the galantan and isofluran-based anesthesia is predictably less rapid. That is the sevoflurane. That is special advice for the introductions these drugs in organism of our patients. Metabolism of the inhaled anesthetics. Modern inhaled anesthetics are emulated mainly by ventilations and are only metabolized to a very small extent. Thus, a metabolism of these drugs does not play a significant role in the terminations of their effect. However, metabolism may have important implications for their toxicity. Galantan is eliminated more rapidly during the recovery than isoflurane, which would not be predicted from their respective tissues' solubility. This increased eliminations occurs because over the 40% of inspirated galantan is metabolized during the average anesthetic procedure, whereas less than 10% of enflurane is metabolized over the same period. In terms of the extent of hepatic metabolism, the rank order of the inhalated anesthetic is, for the first, galantan, enflurane, sevoflurane, isoflurane, desflurane, nitrous oxide. Anesthetic potency is currently described by the minimal alveolar concentrations, MAC, required to prevent the response of the surgical incision. Inhaled anesthetics decrease the metabolic activity of the brain. A decreased cerebral metabolic rate generally causes reductions in blood flow within the brain. However, volatile anesthetics may also produce cerebral vasodilatations, which can increase cerebral blood flow. The net effect of cerebral blood flow, increase, decrease, or not change, depends on the concentrations of the anesthetic delivered. Nitrous oxide can increase cerebral blood flow and cause increased intracranial pressure. This effect is most likely caused by activations of the sympathicotonic nervous systems. Traditionally, anesthetic effects of the brain produce 4 stages or levels of the increasing depth of the central nervous system's depression. Stage 1, analgesia. The patients initially experience analgesia without amnesia. Later, in stage 1, both analgesia and anamnesia are produced. Stage 2, excitement. During this stage, the patient appears delirious and may vocalize, but is completely amnesic. Respiration is rapid, and heart rate and blood pressure increase. Durations and severity of this late stage of anesthesia are shortened by rapidly increasing the concentrations of the agent. Stage 3, surgical anesthesia. This stage begins with the slowing or respirations in heart rate and extend to the complete cessations and spontaneous respirations, apnoea. 4 plans of stage 3 are described based on the changes of the ocular movement, eye reflexes, and pupil size, indications increasing depth of anesthesia. Stage 4, medullary depressions. This deep stage of anesthesia represent severe depressions of the central nervous systems, including the vasomotor center in the medulla and the respiratory center in the brainstem. Without circulatory and respiratory support, death would rapidly enter the stage 4. Cardiovascular effect. Galantan, enflurans, isoflurans, desflurans, and sevoflurans all depress normal cardiac contractility. Galantan and enflurans more so than influenza, disfluenza, and sevoflurane. That's why we don't recommend the prescriptions, the Galantan and influenza if the patient has the ischemic heart disease or another problems with the heart. As a result, all volatile agents tend to decrease mean arterial pressure in direct proportions to the alveolar concentrations. With the Galantan and influenza, the reduced arterial pressure is caused primarily by myocardial depressions, reduced cardiac output, and there is little change in the systematic vascular resistance. In contrast, isoflurane, disflurane, and sevoflurane produce greater vasodilatations with the minimal effect of the cardiac output. Nitrous oxide also depresses myocardial functions in the concentrations-dependent manner, and depressions may be significantly offset by the concomitant activations of the sympathetic nervous systems, resulting in the preservations of cardiac output. Therefore, administrations of the nitrous oxide in combinations with the more potent violative anesthetics can minimize circularity depressant effect by both anesthetic sparing and sympathetic activations action. All volatile anesthetics possess varying degree of the bronchodilatations properties and effect of value on patients with the active within the status asthmaticus, because now we discuss about the respiratory effect of these inhalatic anesthetics. However, airway irritations which may provoke coughing or the breath holding is induced by the pungency of some violative anesthetics. The pungency of the isoflurane and disflurane makes these agents less suitable for inductions of anesthesia in patients with the active bronchospasm. These reactions rarely occur with the Galantan and sevoflurane, which are considered non-pungent. Therefore, the bronchodilation sections of the Galantan and sevoflurane makes them the agent of choice in patients with the underlying airway problems. For example, chronic bronchitis, or for example, insufficiency of the pulmonary systems, bronchial asthma, and others. Nitrous oxide is also non-pungent and can facilitate inhalations, inductions of the anesthesia in patients with the bronchospasm. Inhalation anesthetics tend to decrease glomerular filtrations rate and urine flow, that is the problems of the kidneys after the use of the inhaled anesthetics. Renal blood flow may also be decreased by some agent, but filtration fractions is increased, implying the autoregulatory control of the efferent arterial tone helps compensative and limits the reductions of the glomerular filtrations rate. In general, these anesthetics effects are minor compared with the stress of surgery itself and usually reversible after the discontinuations of the anesthetic. Hepatic effect of the inhalations anesthetics. Violative anesthetics cause of concentration-dependent decrease in portal vein blood flow that parallels the decline of cardiac output produced by these agents. However, total hepatic blood flow may be relatively preserved as hepatic arterial blood flow to the liver may increase or stay the same. Although transient changes in liver function tests may occur following exposure to the volatile anesthetics, persistent elevations in liver enzymes is rare except following repeated exposure to the Galantan. Specific Galantan hepatitis, that is the toxic hepatitis after the using of these drugs, Galantan. Hepatic dysfunctions following surgery and general anesthesia is most likely caused by a hypovolemic shock, very dangerous for all organism because the hypotensions sometimes induce the status of the patients, that is the shock of kidneys, decreasing the BP blood pressure, less than 70 millimeters systolic blood pressure. That is the problems for the circulations of blood into the kidneys. And all time, the reanimatologist check how many BP of these concrete patients. Does this patient has the urinations? Yes or not? Sometimes only 100, 150 milliliters of the urine, absolutely necessary volume for the preventions of the renal shock. That is, volume of the urine cannot compensate of process of the increasing of the renal insufficiency. No, but if you patients now has the urine, we understand these patients now have the circulations of the blood per tissues of the kidneys. If the patient stopping of the process of the filtrations of urine, that is the shock of the kidneys, and sometimes after the recovery of the circulations, we see the absolutely dangerous acute insufficiency and death of kidneys of our patients. The mechanism underlying Halotan hepatotoxicity remain unclear, but studies of the animals implicate to the formations of the reactive metabolites. They are either the cause during the hepatocellular damage of initiative immune-mediated response. Causes of the hepatitis following exposure to other violative anesthetics, including enflurans, isofluran, and desfluran, have rarely been reported. Prolonged exposure of the nitrous oxide decrease methionine synthesis activity with the theoretically cause megaloblastic anemia, B12 folivoacidic anemia. Megaloblastic bone marrow change have been observed in patients after 12-hour exposure to the 50% of the nitrous oxide. Chronic exposure of the dental personals to the nitrous oxide in inadequately ventilated dental operations suit as the potential occupational hazard. All inhaled anesthetics can produce some carbon monoxide from their interactions with strong base in the dry carbon dioxide absorbs. Mutagenity, teratogenity, and reproductive effect of the inhalations drugs for narcosis. Under normal conditions, inhaled anesthetics, including nitrous oxide, are neither mutagens nor carcinogens in patients. Nitrous oxide can be directly teratogenic in animals under conditions of extremely high exposure. Halotan, influrans, isofluran, desfluran, and sevofluran may be teratogenic in rodents as a result of the physiologic changes associated with the anesthesia rather than through a direct teratogenic effect. The most consistent finding in surveys conducted to determine the reproductive success of female operations room personally has been a questionability higher than expected incidence of miscarriages. However, there are several problems in interpreting these studies. The associations of the obstetrics problems with the surgery and anesthesia in pregnant patients is also an important consideration. Intravenous anesthetics, most popular, that is the phos-propofol. The effect profile of the phos-propofol is similar to the propofol, but onset of the recovery are prolonged comparing with the propofol because our prodrug must be converted into the active form. Although patients receiving phos-propofol don't appear to experience the injection span typically of propofol, a common adverse effect is the experience of the paresthesia, often of the perianal region, which occurs maybe in 74% of patients. The mechanism for this effect is unknown. Phos-propofol is approved for sedations during the monitoring anesthesia care. Supplemental oxygen may be administered to all patients receiving the drug. As with the propofol airways, compromise is a major concern. Hence, it is recommended that phos-propofol be administered only by personnel trained in the airway management. Lucedra, phos-propofol. Barbiturates. These sections focuses on this use of the thiopental and methylhexytal for inductions of the general anesthesia. However, these barbiturate hypnotics have been largely replaced as induction agents by propofol. The anesthetic effect of barbiturates presumably involves the combinations of enhancement of inhibitory transmissions and inhibitions of excitatory neurotransmission. Thiopental and metahexytal undergo hepatic metabolism, mostly by oxidations, but also by dealkylations, desulfurations, and destructions of the barbituric acid ring structure. Barbiturates should not be administered to patients with the acute intermittent porphyria because they increase the productions of the porphyrins through stimulations of the aminolevulic acid synthase. Metahexytal has a shorter eliminations half-time than thiopental due to its larger plasma clearance, leading to a faster and more complete recovery after bolus injection. Thiopental for intravenous injection. Effect of the barbiturate to the central nervous systems. Barbiturate produce dose-dependent central nervous system depressions ranging from the sedations to the general anesthesia when administered as bolus injections. They don't produce analgesia. Instead, some evidence suggests they may reduce the pain they showed, causing hyperalgesia. Barbiturates are potent cerebral vasoconstrictors and produce predictable decreases in cerebral blood flow, cerebral blood volume, and disorders. As a result, they decrease of the CMRO consumptions in a dose-dependent manner up to the dose at which they suppressed of the electroencephalography activity. The ability of the barbiturate to decrease of the ICP and CMRO makes these drugs useful in the management of the patients with the space occupation intracranial lesions. They may provide the neuroprotection from local cerebral ischemia, stroke, surgical retractions, temporary eclipse during the aneurysm surgery, but probably not from global cerebral ischemia, for example, cardiac arrest. The decrease of the systematic blood pressure associated with the administrations of the barbiturates for the inductions of the anesthesia is primarily due to the peripheral vasodilatations and is usually smaller than the blood pressure decrease associated with the propofol. There is also direct negative inotropic effect of the heart. However, inhibitions of the baroreceptors reflex as less pronounced than with the propofol. Thus, compensatory increases the heart rate limit the decrease in blood pressure and make up transient. The depressant effect of the systematic blood pressure are increased in patients with the hypovolemia, cardiac tamponade, cardiomyotrophia, myocarditis, ischemic heart disease, coronary artery disease, cardiac valvular disease, because such patients are less able to the compensated process for this effect of peripheral vasodilatations. A hemodynamic effect are also more pronounced with larger dose and rapid injection. Barbiturate has some effect to the respiratory systems, and we must understand this is the serious questions when the patient has the bronchial asthma, chronic obstructive disease of the lungs, chronic bronchitis, and others. Barbiturates are a respiratory depressant, and the usual induction dose of thiopental of metahexytal typically produce transient apnea, which will be more pronounced if the other respiratory depressant are also administered. Barbiturates leads to decreased minute ventilations through the reduced tidal volumes and respiratory rate, and also decrease ventilatory responses to the hypercapnia and hypoxia. Resumptions of the spontaneous breathing after the anesthetic induction dose of a barbiturate of the characterized by a slow breathing rate and decreased tidal volume. Suppressions of the laryngeal reflex and cough reflex is probably not profound as the other after an equinestic propofol administrations, which makes barbiturate an inferior choice of airway instrumentations in the absence of the neuromuscular blocking drugs. That is the metahexytal sodium, 500 milligram, anesthetic barbiturates. Clinical uses of the tiopental. The principal clinical use of the tiopental is for inductions of the anesthesia inconsistencies, which usually occurs in less than 30 seconds. Patients may experience a garlic or onion test after administration. Solutions of tiopental sodium for intravenous injections have a pH range of the 10 to 11 to the mainly stability. Rapid injections with the depolarizations and non-depolarizations muscles relaxants, which have much more the lower pH, may cause precipitations of insoluble thiopentanate acid. The use of the small dose is less frequently associated with the hypotensions, thus making it easier to maintain adequate cerebral perfusion pressure, especially in the setting of the increase of the ICP. Benzodiazepines, commonly used in the perioperative period, include the midazolam, lorazepam, and less frequently diazepam. Benzodiazepines are unique among the group of the intravenous anesthetics in that their actions can readily be terminated by administrations of their selective antagonist flumazenil. Their most desired effects are anxiolysis and antegrade amnesia, which are extremely useful for premedication. Midazolam, 5 milligram in 1 milliliters. Lorazepam, and flumazenil, 1 milligram per 10 milliliters, and we use as an antagonist for the intravenous injections, for stopping of the effectiveness of the drugs from this group. Ketamine. The high rapid solubility of ketamine ensures a rapid onset of its effect. With other intravenous induction drugs, the effect of the single bolus injections is terminated by redistributions to inactive tissue sites. Metabolism occurs primarily in the liver and involves a demethylizations by the cytochrome P450 system. Norketamine, the primary active metabolite, is less potent, 1/3 to 1/5 to the potence of the ketamine, and is the subsequently hydroxylate and conjugate into the water-soluble inactive metabolites that are excreted in urine. Ketamine is the only intravenous anesthetics that has low proteins bidding. Ketamine injections for 500 milligram, 50 milligram in 1 milliliters, and 500 milligrams in 10 milliliters of the ketamine. If ketamine is administered as the sole anesthetics, amnesia is not as complete as with the benzodiazepines. Reflexes are often preserved, but it cannot be assumed that patients are able to protect the upper airway. The eyes remain open and the pupils are moderately dilated with the nystagmic gaze. Frequently, lacrimations and salivations are increased, and premedications with the anticholinergic drugs may be indicated to limit this effect. Ketamine can produce transient but significant increases on the systematic blood pressure, heart rate, cardiac output, presumably by suddenly mediated sympathetic stimulation. This effect, which are associated with increased cardiac forkload and myocardial oxygen consumptions, are not always dosable and can be blunted by the co-administrations of the benzodiazepine opioids of inhalated anesthetics. In its unique properties, including the profound analgesia, stimulations of the sympathetic atonic nervous systems, bronchodilatations, and minimal respirations depressions, make ketamine an important alternative to the other intravenous anesthetic and the desirable adjunct. There are many cases dispute the unpleasant, the psychotomimetic effect. Moreover, ketamine can be administered by multiple routes: intravenous, intramuscular, oral, rectal, epidural, thus making it useful options for the premedications in mentally challenged and uncooperative pediatric patients. The use of the ketamine has always been limited by its unpleasant psychotomimetic side effects, but its unique features make it a very valuable alternative in certain settings, mostly because of the potent analgesia with minimal respiratory depressions. Most recently, it has become popular as an adjunct administered at the subanalgesic dose to limit or reserve opioid tolerance. Absorption of local anesthetics. Systematic absorptions of the injected local anesthetic from the site of administrations is determined by several factors, including dosage, site of injections, drug tissues binding, local tissues, blood flow, use of the vasoconstrictors, epinephrine, and the physical-chemical properties of the drugs itself. Anesthetics, therefore, they are more lipid-soluble, are generally more potent, have a longer durations of actions, and take longer to achieve their clinical effect. Extensive proteins binding also serve to the increase of the durations of action. A local anesthetic is usually injected directly at the site of the target organ distribution within the compartment, plays an essential role with respect to the achievement of clinical effect. For example, anesthetic derived into the subarachnoid place will be diluted with the cerebrospinal fluid, and the pattern of the distributions will be depend upon the host of the factors, among the most critical being the specific gravity relative to the CSF and the patient's positions. Solutions of the term hyperbaric, isobaric, or hypobaric and will respectively descend remain relatively static of the ascent within the subarachnoid space due to the gravity when the patient sits upright. The peak blood levels achieved during the major conductions anesthesia will be minimally affected by the concentrations of the anesthetic or the speed of injections. The depositions of these agents can be well approximated by the two compared model. The initial alpha phase reflect rapid distributions in blood and highly perfused organs, brain, liver, heart, kidneys, characterized by the step exponential decline in the concentration. This followed by the slow decline in beta phase reflections, distributions into the less with the perfused tissues, muscles, gut, and may assume to the nearly linear rate of the decline. The potential toxicity of the local anesthetic is affected by the protective effect afforded by uptake by the lungs, which serve of the attended the arterial concentrations through the time course and magnitude of the effect have not been adequately characterized. The local anesthetics are converted to more water-soluble metabolites in the liver, amide type, and in plasma ester type, which is excreted in the urine. Since local anesthetics in the uncharged from the diffuse readily through lipid membranes, little up to the urinary excretions of the neural form occurs. Acidification of urine promotes ionization of the tertiary amine base to the more water-soluble charged form, leading to more rapid elimination. That is the procaine, chlorhydrat procaine. 1 milliliter contain the 10 milligram of these drugs. Nezacaine, chloroprocaine, H-chlor injections, 2% solution. 1 milliliter contain the 20 milligram of the chloroprocaine. The amide local anesthetics undergo complex biotransformations in the liver, which include the hydroxylations and dealkalizations by liver microsomal cytochrome P450 isoenzymes, cytochrome oxidase. There is considerable variations in the rate of the liver metabolism of individual amide compounds with the prilocaine, fasted, lidocaine, mepivacaine, ropivacaine, buvivacaine, and levobuvicaine, slowest. As a result, toxicity from the amide type local anesthetics is more likely to occur in patients with the hepatic disease. For example, for external use only, linacaine and prilocaine cream, combinations of these two anesthetic drugs. Lignocaine and prilocaine. Bupivacaine, 0.5% solution, 20 milliliters contain the 100 milligram of these drugs. 1 milliliter contain 5 milligram of the bupivacaine. Several benefits may be derived from the additions of the vasoconstrictors to the local anesthetics. First, localized neuronal uptake to the enhanced because of highest sustained local tissues concentrations that they can translate clinically into the longer durations block. Well, this is the classic variant of the pharmacokinetics synergism because the vasoconstrictors increase the concentrations of these drugs in local place, but maybe the results of this increasing of the concentrations, that is the increasing of the effectiveness, pharmacodynamics positive effect. This may enable adequate anesthesia for more prolonged procedure, extended durations of postoperative pain control, and lower total anesthetic requirement. Second peak, blood levels will be lowered as the absorption is more closely matched to the metabolism and eliminations, and the risk of the systematic toxic effect is reduced. Moreover, when incorporated into the spinal anesthetics, epinephrine may not only contribute to prolongations of the local anesthetic effect, where it's the vasoconstrictor's properties, but also exert a direct analgesic effect mediated by postsynaptic alpha-2 adrenergic receptors within the spinal cord. Recognition of this potential has led to the clinical use of the alpha-2 agonist clonidine as a local anesthetic adjuvant for the spinal anesthesia. The dose of the local anesthetic used for the epidural anesthesia of high-volume peripheral blocks is sufficient to produce major clinical toxicity, even death. To minimize the risk, minimum recommendations dose for each drugs for each general applications have been promulgated. Neural injury. When large doses of the local anesthetic are required, for example, for major peripheral nerve block or local infiltrations for major plastic surgery, premedications with the parenteral benzodiazepine, diazepam, or midazolam will provide some prophylaxis against the local anesthetic-induced central nervous system's toxicity. However, such premedications will have little, if any, effect on cardiovascular toxicity, potentially delaying recognitions of the life-threatening overdose. If seizures too do occur, it is critical to prevent hypoxemia and acidosis, which potential anesthetic toxicity. Rapid tracheal intubations can facilitate adequate ventilations and oxygenations and is essential to prevent pulmonary aspirations or gastric contents in the patients at risk. Benzocaine. Benzocaine's pronounced lipophility has the relegate its applications to the topical anesthesia. However, dispute over of the center of use for this purpose, its popularity has recently diminished owing to the increasing concern regarding its potentials to reduce methylmalabinamia. Elevated levels can be due to the inborn errors or can occur with the exposure to an oxidizing agent, and such is the case with the significant exposure to the benzocaine. Because the methylmalabine does not transport oxygen, elevated level pose serious risk with the severity obviously paralleling blood levels. For example, that is the benzocaine for the local anesthetic effect. Bupivacaine. Based on the concerns for the cardiotoxicity, bupivacaine is often avoided for techniques that demand high volume of the concentrated anesthetic, such as epidural of the peripheral nerve blockers performed for the surgical anesthesia. In contrast, reliability, low concentrations are frequently used to achieve prolonged peripheral anesthesia and analgesia for the post-operative pain control, and the drug enjoys similar popularity where the anesthetic infiltrations is used to control pain from a surgical incision. It is often our agent of the choice for epidural infusions used for the post-operative pain control and for labor analgesia. Finally, it has a comparability unblemished record as a spinal anesthetics with a relatively favorable therapeutic index with respect to the neurotoxicity and little, if any, risk to the toxic effect on the nervous systems. Bupivacaine, 0.5% in 1 milliliter. 1 milliliter of these drugs contain the 5 milligram of the bupivacaine. Chloroprocaine. Practically, chloroprocaine, the inductions of the chloroprocaine into the clinical practice in 1951 represented the reversions to the early amino ester template. Chloroprocaine gained widespread use as an epidural agent on obstetrical analgesia, where its hydrolysis served the minimum risk to the systematic toxicity or fetal exposure. The unfortunate report of neurologic injury associated with the apparent intrathecal misplacement or large dose intended for the epidural play space led to its near abandonment. However, the frequent of the occurs of the toxic effect with the lidocaine administered as a spinal anesthetic has created an anesthetic void the chloroprocaine appears well suited to fill. Chloroprocaine H-chlor injections, 1 milliliter contain the 20 milligram of the chloroprocaine. Atidocaine, introduced along the bupivacaine, atidocaine has had limited applications due to its poor block characteristics. It has a tendency to produce an inverse differential block. Compared with other anesthetics such as bupivacaine, it produces excessive motor relatively to sensory block, which is rarely as a favorable attribute. Levobupivacaine, levobupivacaine. As previously discussed, the S enantiomer of the bupivacaine is somewhat less cardiotoxic than the racemic mixture. It is also less potent of the tends to have a longer durations of actions, although the magnitude of this effect is too small to have any substance's clinical significance. Recent work with the lipid resuscitation subject to the potential advantages of the levobupivacaine over ropivacaine, as the former is the more effective secondary into the so-called lipid sink, implying the greater ability to reverse toxic effect should they occur. Lidocaine, very popular drugs. Aside from the issues of the high incidence of the TNS, with the spinal administrations, lidocaine has had an excellent record as an intermediate durations anesthetic and remind the reference stand against which the monostatic are compared. We must remember in your questions in the CROC 2, you can find the questions, can we add the lidocaine to the ceftriaxone, that is the antibiotics from the group of the cephalosporins, before the intramuscular injections? Yes. If we forget of the using of the lidocaine, 1% 5 milliliters to the 1 gram, for example, ceftriaxone, the patients will feel very, very intensive pain in the intramuscular injections. That's why remember that ceftriaxone prescriptions as intramuscular injections need the adding the solutions of the lidocaine, 1% 5 milliliters. Another questions, if the patients after the using of the local anesthetic, for example, lidocaine, novocaine, bupivacaine, has the symptoms of the anaphylactic reactions, you must remember about the strategy of the emergency help. For the first 1-2 milliliters of the adrenaline as intramuscular injections per kilodes in legs without any aseptic, antiseptic, and others. Immediately now, 1-2 milliliters adrenaline, epinephrine, and next step, immediately you must introduce 5-6 milliliters dexamethasone. 1 milliliters of the dexamethasone contain the 4 milligram, and you must introduce 5-6 milliliters immediately intramuscular. If you will find the venous in these situations, you must understand this procedure needs many time. Why? Because the patient has the hypotonia, spasm, venous spasm, and we cannot find quickly the introduction's place of our drugs. That's why intramuscular injections, dexamethasone, 4-5-6 milliliters, or prednisolone, 1 milliliters of the prednisolone contain the 30 milligram, for example, European and Ukrainian variant of the prednisone, or 25 milligram of Indian variant of the prednisolone, but 5-6 milliliters after the adrenaline therapy. If you will provide a quick treatments of these anaphylactic reactions of your patients, you will save the life of these patients. Mepivacaine, although structurally similar to the bupivacaine and ropivacaine, mepivacaine displays clinical properties that are comparable to lidocaine. However, it differs from lidocaine with respect to the vasoactivity, as it has a tendency toward vasoconstrictions rather than vasodilatations. These characteristics account to its slightly longer durations of actions, which has made a popular choice for major peripheral blocks. Lidocaine has retained its dominance over mepivacaine for epidural anesthesia, where the routine placement of the catheter negates of the importance of the longer durations. More importantly, mepivacaine is slowly metabolized by the fetus, making it the poor choice for epidural anesthesia in the parturient. When used for spinal anesthesia, mepivacaine has a slightly lower incidence of the TNS than lidocaine. Classic variant, mepivacaine hydrochloride without the vasoconstriction. because sometimes we can add the vasoconstrictions, noradrenaline, for increasing of the effectiveness. But this special form, mepivacaine hydrochloride, 3% without vasoconstrictions. Practically any cartridge contains the 1.7 milliliters of these drugs, Scandonest. Prilocaine. Prilocaine has the highest clearance of the amide anesthetics, impairing a reduced risk of the systematic toxicity. Unfortunately, this is the somewhat offset by its propensity to induce methemoglobinemia, which results from the accumulation of one of its metabolites, orthotoluidine, and oxidizing agent. As a spinal anesthetic, prilocaine durations of actions of the slightly longer than that of lidocaine, and the limited data suggest it carries a low risk of the TNS. It is gaining increased use for spinal anesthesia in Europe, where it has been market specific for this purpose. That is the combinations, for example, using of lidocaine and prilocaine in one cream for the local anesthetic effect. 10 grams. Ropivacaine. Ropivacaine is an enantiomer of the gomologous series that includes the bupivacaine and mepivacaine. This distinguished by its chirality and the propyl group of the piperidine ring. Its perceived reduced cardiotoxicity has led to the widespread use for the high-volume peripheral blocks. It is also a popular choice for epidural infusions for control of labor and postoperative pain, although there is some evidence to suggest that ropivacaine might produce a more favorable differential block than bupivacaine. The lack of the equivalent clinical potency adds complexity to such comparisons. That is the ropivacaine hydrochloride. 1 milliliter contains the 2 milligram of these drugs. 20 milliliters, 40 milligrams. For infiltrations, nerve block, and epidural administration only, and not for the intravenous administration. Thank you for your attention.